This key term is neurocognitive disorder due to Alzheimer's disease. Alzheimer's disease is an irreversible, progressive brain disease that causes neuronal dysfunction, decrease in interconnections among neurons, and eventual death of those brain cells, leading to impairment in cognitive function. Symptoms are insidious and develop gradually over time over a period of years, and typically begin with memory problems. But all domains of cognition can be affected in the course of the disease. Complex attention, which is selective attention, processing speed, executive function, like word finding, planning, or reasoning. Learning and memory, such as immediate memory, cued recall, autobiographical memory. Language, expressive and receptive. Perceptual motor abilities, visual perception, perceptual motor, and social cognition, recognition of emotions. Thus, the DSM-5 designates the generation of cognitive function as a neurocognitive disorder in place of the term previously used, dementia. Neurocognitive disorders are classified according to etiology, for example, degenerative, vascular, traumatic, and described according to severity. A mild neurocognitive disorder indicates decline from a previous level of performance in one or more cognitive domains, but the cognitive impairment does not interfere with capacity for independence in activities of daily living. In contrast, when cognitive impairment worsens to the point of interfering with independence in everyday activities, such as requiring assistance in paying bills or managing medications, it is named a major neurocognitive disorder. The severity of symptoms varies according to how far the disease has progressed and can be generally assessed and tracked over time by neurocognitive measures, including the mental status examination. When clinically significant cognitive impairments are presumably caused by Alzheimer's disease, the diagnosis is mild or major neurocognitive disorder due to Alzheimer's disease. The clinician will indicate probable Alzheimer's disease if there is evidence of causative generative mutation from genetic testing or family history, or probable Alzheimer's disease in the absence of a genetic causative factor. Diagnostic symptoms are three. A. Clear evidence of decline in memory and learning, for mild cases. For major cases, there must also be at least one other cognitive domain affected. B. Steadily progressive gradual decline in cognition without extended plateaus. No evidence of mixed etiology. And C. No evidence of mixed etiology. The presumption of cause in the case of Alzheimer's disease is because at this time there are no effective tests to prove conclusively the etiology of the cognitive decline. Thus, the diagnosis of neurocognitive disorder due to Alzheimer's disease is made through a process of elimination of other verifiable etiologies, for example, vascular disease, traumatic brain injury, Parkinson's disease. It is encouraging to know that several biomarkers and imaging techniques are being developed to help with future early diagnosis in everyday medical practice. Alzheimer's disease is the most common cause of degenerative neurocognitive function, but the disease is not well understood. The greatest known risk factor for developing Alzheimer's disease is increase in age. U.S. Census data estimates that approximately 7% of individuals diagnosed with Alzheimer's disease are between the ages of 65 and 74 years old. 53% are between ages 75 and 84, and 40% are 85 and older. Family history and genetics are considered a risk factor, but less than 5% of the time Alzheimer's is caused by specific genetic changes. In most cases, it appears that genetic, lifestyle, and environmental factors combined to affect the brain over time. Other risk factors include being female, in part because women live longer, history of head trauma, lack of exercise, high blood pressure, poorly controlled diabetes, lack of fruit and vegetables in one's diet, and a life with limited mental or social stimulation, like having little or no stimulation in one's job, limited social interactions, not engaging in mentally stimulating activities such as reading or playing musical instruments. The course of illness is protracted. Damage to the brain starts about a decade before problems become clinically evident, with neurocognitive decline appearing insidiously, progressing gradually, sometimes with brief plateaus, through severe dementia to death. The mean duration of survival after diagnosis is approximately 10 years, but some can live as long as 20 years with a diagnosis, depending on the age of onset. Onset of symptoms is usually in the 8th or 9th decade of life, with early onset forms seen in the 5th or 6th decades of life and are often caused by genetic mutations. Differential diagnoses must be done with other causes of neurocognitive disorders, or neurological or systemic illness, and major depressive disorder. The older the individual, the more medical comorbidities may exist, which cloud the diagnosis and complicate treatment. The younger the age of onset, the more likely the individual will survive the course of treatment of the disease, with eventual death being due to aspiration, after a period of being mute or bedbound. Currently, confirmation of diagnosis is made post-mortem. Histopathological examination reveals the presence of two characteristic markers of the disease, beta amyloid plaques and tau tangles. In early-stage Alzheimer's disease, that is, within the first 3 years after symptom onset, the individuals demonstrate forgetfulness, a propensity for misplacing items, decreased interest in usual activities, lower energy levels, reduced awareness of current events, diminished ability to perform complex tasks, for example, higher-level mathematical operations or managing their finances, deficits in new learning, anomia, sadness, and a detached or muted affect when placed in mentally or socially demanding environments. Alterations in or loss of cholinergic neurons have also been found in the early stages. Although deficits in episodic memory are most apparent in this stage, slight impairments in somatic memory may occur. In mid-stage Alzheimer's disease, that is 3 to 10 years after symptom onset, individuals with this disorder often need help with activities of daily living. For example, choosing weather-appropriate clothing, dressing themselves, or toileting. They are unable to perform simple mental arithmetic, for example, counting backwards from 20 by twos. They demonstrate personality changes, such as becoming suspicious or fearful. They experience delusions or hallucinations. They may wander off, suffer from aphasia, that is, forgetting common words or making unusual word substitutions. They can demonstrate increased restlessness and exhibit increased mood lability, including increased irritability as well. It is during this stage that individuals begin to have difficulty remembering the names of significant people in their lives, although they are generally able to distinguish familiar from unfamiliar faces. Symptoms may include impulsive behaviors, in addition to hallucinations, delusions, and/or paranoia. In late-stage Alzheimer's disease, damage has spread throughout the brain and brain tissue has shrunk significantly. Individuals are no longer able to meaningfully respond to their environment and are usually incapable of producing recognizable speech. Basic activities such as eating and toileting require assistance. Motor coordination is impaired to the point that they are unable to walk or sit upright without assistance. Limb rigidity and flexion posture are common. The disease will eventually render the person bedridden. During late-stage Alzheimer's disease, seizures may develop. The time of onset to death is generally about 10 years, although there have been reports of death due to the disorder in as little as 4 years or as many as 20 years after symptom onset. Both Alzheimer's disease and Korsakoff syndrome share similar symptoms during the early stages of the disease, such as anterograde amnesia for declarative speech. Alzheimer's disease can be differentiated symptomatically from Korsakoff syndrome by the presence of cognitive deficits beyond the amnesia. Research has shown that symptomology for depression associated with Alzheimer's disease is slightly different than other types of mood disorders. The first stage of depression in individuals with Alzheimer's is marked by anomia, irritability, and anger. The second stage is characterized by paranoia and lability in mood. At the third stage, the patient may exhibit apathy and emotional blunting. Most of these symptoms are similar to those needed for a major depressive disorder diagnosis. It should be noted that a characteristic symptom of depression with Alzheimer's disease is decreased positive affect or pleasure in response to social contacts and usual activities. Let's practice with a question for neurocognitive disorder. Gina, who has had Alzheimer's disease for 3.5 years, believes and feels that she has bugs crawling all over her body, is constantly restless, and is not able to teach her grandchildren basic addition problems. The symptoms Gina is experiencing is answer A, early stage Alzheimer's disease, B, late stage Alzheimer's disease, C, mid stage Alzheimer's disease, or D, post stage Alzheimer's disease. The correct answer is C, In mid-stage Alzheimer's disease, that is 3 to 10 years after symptom onset, individuals with the disorder often need help with activities of daily living, such as choosing weather-appropriate clothing or dressing themselves, or with their toileting. And they're unable to perform simple mental arithmetic, such as counting backwards from 20 by twos. They also demonstrate personality changes. For example, they may become suspicious or fearful. They may experience delusions or hallucinations. They can wander off or suffer from aphasia, that is, forgetting common words, or they might make unusual word substitutions. They can also demonstrate increased restlessness, and they can exhibit increased mood lability, including increased irritability. We invite you to participate in the next chapter of our series on the key term areas affected by the DSM-5. Thanks for joining us.